story.
Good morning, everyone.
Morning.
Jim Augustine, privileged to be a member of the department for a long time, and I'm bringing you cases today from Washington Township. This is a number of years of dealing with the most unusual heart and lung emergencies that really brings us to training today. There is a lot changing in this field, and a lot of really exciting things that lend us to a good future for ourselves and for our parents and ultimately for our kids, but makes it very difficult for us to figure out what to do. So beyond what the protocols tell us, heart and lung emergencies are something where we really need to prioritize what we're doing. So we'll talk today about heart and lung presentations, match it with what's in the protocols, but a little bit about critical thinking on your guys' part. For us, it's what happened, so why did we get called? What can we assess? What can we treat? Very important for us here in the township is where do we need to transport these people to? Because there's significant differences in the capabilities of the hospitals in the community. And then what is going to happen to us, just so all of you know. Eventually, just like we have burn centers and we have trauma centers and we have pediatric centers, there's going to be what are called resuscitation centers. And the resuscitation centers will be where we primarily take our cardiac arrest patients, and it will not be every hospital. And it's about the capabilities of dealing with somebody who we resuscitate and what services should be available afterwards. Let's do a routine summer call here. So 46-year-old male who perhaps is at one of our local golf courses. And we get, of course, ill calls. And as always, in the township here, it's not here just in the township. This is the law across the nation. It is the law of inverse dispatching. Anybody familiar with it? If this morning you go out and dispatch sends you out on a call with wreck, with people trapped and cars on fire, what are you going to find?
People standing outside.
Yeah, people with nothing going on. And today you'll get an ill call, and it will turn into the big one. And that law is followed, just so you know, across the nation. We have no special privilege here. And for Washington Township, though, we do have one special privilege, which is the first call is never the interesting one. And for those of you who think through what goes on around here, the first call is only to distract resources to someplace else when the more active call comes in. So anyway, it's a ill call. 46-year-old male. He's at a local golf course. Somebody else called, and he says, "I just don't feel good. I think I just need to go home and cool down." And he has no heart history. He was just nauseated, a little short breath on a hot day out on the golf course. And so what are we going to do with this guy? Send him home?
No.
42s want to send him home? Okay. Well, the mood in the room here is let's not send him home. So somebody says let's do a 12 lead. And for the paramedics here, I intentionally don't make this really clear because it wasn't really clear that day. But for the paramedics, you would say those ST segments in inferior leads. So 2-3 AVF for the paramedics who are watching online. 2-3 and AVF don't look quite right. And across the anterior leads, you notice some ST segment depression. But the gentleman says, "I'll go home, call my wife. She's coming to pick me up." What do you think?
You do your best to get them to go to the hospital.
Yeah.
Explain the risk of what's going on.
Yeah, but I don't have any chest pain, sir. That disqualifies me from having any emergency, right?
Atypical response
Yeah, which is now what used to be atypical, which is now typical. So this is his EKG. 12 minutes after transport and 8 minutes in the emergency department. And for the EMTs, those are called tombstones to reflect the amount of damage going on in the heart. And this is a typical problem in our modern society. People do not read textbooks. They refuse to present with typical symptoms. They're supposed to have elephants on their chest. They're supposed to be short of breath. They're supposed to be sweaty. They're supposed to have heart palpitations, and they're supposed to be nauseated. Isn't that what acute MIs are all about? That's the symptoms they're supposed to present with. But they will not read textbooks, and so they will present with anything but that. And that follows the rules in the pre-hospital setting and in the emergency department setting. And if you notice, many people coming into the emergency department get EKGs done, 12-lead EKGs done, essentially for a complaint from the chin to the butt. If they're in that risk group and they have a complaint from here to here, they get a 12-lead EKG, because it is rare that we have a chest pain patient present with an acute MI in the emergency setting. And we have to catch these all quickly, because are there good therapies for acute inferior MIs? There's great therapies. And in a 46-year-old, you don't want to let that guy go rolling home with his wife. And this is, the other problem here is many people who have these diseases of the heart and lungs, they don't have a one-time presentation. They have what we call stuttering presentations. So they'll have some symptoms and then they'll go away. And they'll have some symptoms and they'll go away. And this gentleman was having these waves of nausea, which is typical, and then essentially what's happening is he's got a critically blocked coronary artery. It's 95% full of gunk, and then a little bitty clot completes the last 5%, and then the body dissolves it a little bit. It opens up a little bit. A few red cells are going through carrying some oxygen, and he feels better, and then another little clot comes through. And so those are stuttering symptoms. And stuttering is really important that we not miss when they're having the acute symptoms. Okay, second case. This is a gentleman who presents by EMS. The call was for an illness, and the chief complaint is, I'm just too weak. And it's another gentleman who says to the EMS crew, I was so weak, and I felt so weak over the last 24 hours, I just couldn't drive myself to the hospital. But I can't do anything. I don't feel I can raise my arms. The medic crew appropriately puts finger on his pulse and notice it's very slow. Ask the gentleman, sir, is your pulse usually slow? No, it's not slow. It's usually, around 70 or 80 or whatever it's supposed to be. Kind of a cranky old man. Everybody got the picture? And he says he's having no chest pain. So this is kind of a picture of what that guy looked like. And he's angry at the crew as they walk in the emergency department because they reflected this in the monitor to me. Said this gentleman's weak, but we notice his pulse is real slow. He's got a paced rhythm, and in very colorful language he says, I've told you 10 times I don't have a pacemaker in. I do not have a pacemaker in. Okay, so they wheel him in a room and I follow in. And here's this gentleman, I feel weak. Sir, there's a box in your chest. I feel it right there. You know that thing I'm feeling right there? Yeah, it's pacing your heart. Golly darn, no sir, that's not a pacemaker. It's a defibrillator. Okay, it's a defibrillator. Has it gone off, sir? No. Are you having any other symptoms of any kind? Short of breath, sweaty, heart irregular beats, etc. And he says, no. So the tech comes in, and we don't have the interrogation devices, or what they're called. A little device they put over the top of it, and it asks the box what you've been doing. Whether it's a pacemaker or defibrillator or something else, what have you been doing with yourself? And the tech comes back out into the emergency department with me, puts the sheet down that has the report and says, I've taken care of your guy in bed 6. He's been dead 25 times in the last 40 hours. But he's fine now, and the cardiologist said if his troponin level is negative, you can send him home. I said, that's really interesting. Tell me what that little report says. It says he was defibrillated 24 times, starting 40 hours ago. And on the 24th defibrillation, his heart went into asystole. And all modern day defibrillators have a built-in rescue pacemaker. And that rescue pacemaker is at an intentionally very slow rate so that it captures the attention of the patient and they'll go get care just like this guy did. the tech says, I've set the rate up to 75. I sent the report to the cardiologist who said that's the rate he wants him at, and he wants him in next week to have some new wires installed so that he has a permanent pacemaker in. And if his troponin level is 0, you'll send him home. So this guy's been dead 25 times. And I'm going to discharge his troponin level is 0. I send him home from the emergency department with a much better attitude because he felt a little bit better. A few donuts and his pacemaker running at 75 beats a minute. He's in better shape. And we have all these devices out in the field and that you guys have run across. And some people are carrying a little black bag and they have no pulse, and you get a call for them. And so I can't even teach you. I can't teach myself. We don't have these devices sitting one by one in the emergency department. And so just like you, when there's a problem with one of these new devices, pumps, electrical devices, combination devices, or LVADs, we have to call the 1-800 number. And sometimes the person has a personal version of the interrogation device that they put over the top with their cell phone, send a report to wherever in the cloud there's somebody who does troubleshooting. And our job is to link those people together. And believe it or not, sometimes in the ED, we have to move them to an outside bed because inside the walls of the emergency department, it won't run the signal across that we need to get the answer about what to do with this individual. So let's talk about LVADs. So there's a bag and the people don't have a pulse. What does that mean about the devices that we use to assess people? What is going to work on this individual?
Nothing.
What of our monitors will work on an individual who says, I don't feel well and I have an LVAD in? We have one device that will work.
A glucometer.
We'll talk about it later. The glucometer will still work, yeah, it will. End-tidal CO2. End-tidal CO2. But your blood pressure cuff ain't going to work. Your fingers aren't going to work. That's the ultimate monitor, is your fingers. And then anything that measures based on pulse, like pulse oximetry, won't work. And so you have to go to an exhaust meter, which is end-tidal CO2, to see how they're doing. In general, do we have anything to help these people? The only thing that we have is an IV and some fluids. Because one of the things we know about LVAD patients is they are thinned to the max. Any of these devices that are assisting pumping in the heart, so if anybody says I have an assist device, or they're wearing a vest, and they say they can't take the vest off because it has this and that, all that, and you're like, and it's got wires going in or something, you go, not taking any of that off. If the assist device is supposed to work, we're going to leave it in place. And all of them have to be thinned. And so what emergencies oftentimes do they have? They're bleeding somewhere. And we do have an answer for that. We can give them some fluids in response to that. And it's really hard in these people if they say, I just feel plain weak, and you can't get a pressure, and you're doing capillary refill, and you're looking at their eyes to see if they look anemic. Are you bleeding anywhere? Have you bled anywhere? What do your stools look like? Are they really black? If so, sometimes they're starting to bleed and can bleed, as you know, very intensely. And we can miss that originally. So that's one we have to think through a little bit. So the end result here on all of these devices, they're coming out with them so fast we can't keep up with them. Do we have any troubleshooting functions that we can teach you about? We really don't. We don't have replacement chargers, which is oftentimes the issue. They've come somewhere and their charger device won't work, and they're worried because now it's showing battery low, and for you guys, because we're on the interstate here, you'll have out-of-town people who will come and say, you know, I have this and I don't have a charger device, where can I go to get a charger? We don't carry in the medic. We don't go down to Walmart and pick them up. Have you contacted your 1-800 number? Do they have a local version of this? Because sometimes either the Premier network or the Kettering network are tied into whatever network they're involved in, and go to, you know, a hospital where they have a replacement device, or we have a medical supplier and we'll try to get it because they should have 24-hour availability. So we can do that. Number two, we can call the 1-800 number or assist the person calling the 1-800 number. Number three, we can transport them if they're having medical distress and we can't figure it out in the field. Fair enough? We could run through all these devices and by next week it would be outdated knowledge, and it would be dangerous for us to try to troubleshoot these. Fair enough? Okay, so let's talk about stuff that's success stories. So I want you to know I started studying cardiac arrest in Montgomery County in the late 70s, early 80s. At that time, we used to run 4 to 5 cardiac arrests a day in this community. I was working at that time in Kettering Fire Department and West Carrollton Fire Department. We had lots of 50-year-old men in V-fib. We used to shock them. Medic 1 had a defibrillator you had to carry in 2 hands. Medic 2 had a LifePak 5. The most creative, innovative piece of equipment ever came out in EMS with a little lightweight LifePak 5. We would shock people and get them back, and then we would take them to Kettering Hospital for treatment. The treatment was 2 weeks of bed rest on heparin for an acute MI. Do you think those people lived long after their cardiac arrest? You know, we felt great because we got it back. We felt great. We did our job, didn't we? But they didn't have a long life ahead of them. As we began in the 80s to replumb people, if you want to think about it that way, cut their chest open and put in new arteries and put in pacemakers, we began to see people living longer, and look what happened to our numbers of cardiac arrests. And so now Montgomery County runs about 1 cardiac arrest a day. With my work in Atlanta, Georgia, Atlanta Fire had 1 cardiac arrest a day. In Washington, D.C., where I served as Assistant Fire Chief and Medical Director, we had 1.2 cardiac arrests per day. Our resuscitation rates in any of those 3 places, high or low? Very low. Okay. And what's the typical presentation rhythm nowadays in any of those 3 places? Asystole. And what's the age group? 80, 90. What's the typical story? I don't know. They were down. We didn't find them. And we get a call. And I'm sorry, we do not have Jesus powers yet in EMS, and we can't resuscitate people from asystole. So is that a failure story or a success story that we can't resuscitate people in 2019 from cardiac arrest? Failure or success? Do you feel bad about that, or do you feel good about that? And which would you rather do? Prevent stuff like that, or come out here and say, we prevented everybody we could, and people that are left, we're going to do our best, because we still have people who are young and viable, and we want to get them back. But we should not feel bad that we have saved people from having cardiac arrest rather than trying to resuscitate them when they go down. That is a success story. And I want to tell you, globally, that means all of the programs that you all have been involved in, and all of the stuff that you know doesn't get you on the news, but going and teaching people how to put seatbelts on, and telling the kids about putting helmets on, and keeping people from drinking and driving, and going to see their cardiologist, etc. You have prevented people from dying prematurely, and that is a tremendous success story. Does the healthcare system cost more now than it did 40 years ago? Costs more. And you all will live longer, and you will benefit from your kids living longer than you because of that. And that's a tremendous success story. So don't ever forget how much you contribute to preventing people from dying early. And the fact that we aren't pulling people out of burned houses and burned cars, and that we don't have 2-year-olds that are burned really badly anymore, is a real big success story for the fire service. And we need to keep that going. And in the cardiac arrest world, it means we don't have 50-year-olds in VFib very often. And we have to deal with, 80-year-olds that we're making good decisions on when we find them in asystole, and somebody just said they went to bed last night and didn't wake up this morning. All right. Good news. Prevention is still the key. And lots of people running around on blood thinners, because once you get to my age, the tendency is that you go on a blood thinner of some kind, whether it's aspirin or any of the new named products and heparins and all that kind of stuff. And many old people, and that results in you getting more calls, doesn't it? Because when they fall and go boom, or it's dry in their house in February and their nose explodes in blood, you're going to get a call. Because blood still results in 911 calls at a disproportionate level. All right, so let's talk about the cardiovascular system and why all these new devices. Is there anything really complicated about the cardiovascular system? when I teach this, this is just like teaching you about running the pump on 45s. It's a two-stage pump, it's got wiring. And the only thing that is different in the human body is that the piping is smart. So rather than the pump operators standing at the pump panel and watching what's going on with the different lines that are off, in the house somewhere, if you had something where automatically the nozzle is feeding back information and adjusting the pump and doing all of the things that are necessary to give the person the exact amount of water that they need at the end of the nozzle, we would simulate the human system. Our tools for looking at that system, the very best tool that you have, of course, is your fingers. The number 2 best tool that we have is a pulse oximeter. And why would I say pulse oximeter is a really great monitor tool for us? And why do I carry one with me? I don't carry a life pack with me. I don't carry a Zoll monitor with me. I carry this. Why is that? Let's just give you an answer about it.
Pulse now too.
It gives me pulse and oxygen saturation, which is essentially the function of the body. And if things are going well here and it's beeping at a regular level, this gives me a ton of information. There are a few cases where a 12 lead is really nice to have. There are some cases where we'll talk about end-tidal CO2, but the ultimate monitor beyond your fingers is your pulse oximeter with its very simple functions. Then I talked about the end-tidal CO2. So the end-tidal CO2, if there's a problem on 45s and you take it to the shop, one of the ways that they find out what's going on with 45s is they stick a plug in the exhaust pipe and they run a monitor on the plug and say what's going on with the engine in 45. Well, it's running too rich, or it's not doing this, or something else is haywire. End-tidal CO2 is much the same for the human body. Don't put it in the wrong end, okay? It goes in this end because your exhaust system comes out the same way that good stuff goes in. That's a weird way humans were put together, but we have to measure what's coming out, and that's end-tidal CO2. And if the engine is running well, what is the number that shows up on end-tidal CO2?
35 to 45.
35, 40, somewhere in there, and that's when your engine is running well. If it's too low, it means something's not right. If it's too high, it means there's a long-term problem, that something hasn't been running right for a very long time. So those are 2 things, and then I'll give you the 3 lead and the 12 lead. Because looking at wiring is just one very small way of really looking at how the human is. So don't think of the 3 lead as the ultimate way to look at patients. It has very limited amount of information it gives us compared to the other things. All right, smart piping means that all of the blood vessels are like cotton jacketed hose, old cotton jacketed hose. If you run cotton jacketed hose out on a scene and enough people run over it after a while, what happens to the hose? It begins to separate and it bulges. And if they run over it in a number of places, and in one scenario it begins to expand the bulge this way before it expands it this way. And that's what happens in your body with long-term high blood pressure and with certain diseases. And so don't think of aneurysms as anything more complicated than a bulge in a cotton jacketed hose. And it can bulge for a while, but eventually the bulge is going to be large enough that it will rupture. So that's what ruptured aortic aneurysms are. And dissecting aortic aneurysms is what happens in the chest. And in the chest it begins to separate the layers. And typically it just keeps separating them as it moves down the length of the aorta until finally it finds a weak point, which is oftentimes in the belly somewhere, and then it will rupture there. So dissections have a little bit different presentation than ruptured aneurysms, and they're in 2 different areas. Any artery can have an aneurysm, just so you know. Some of you have felt people before who, dialysis patients oftentimes who've had a lot of procedures that'll weaken one of their arteries and it'll begin to bulge, and somebody will tell you, have you aneurysm? If you try to feel the pulse in my groin, it's like boing, 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 and they're going to do something about it, or they can't do anything about it right now. Anyway, I want you to understand that's what the important role of the aorta. And very, very importantly, when something begins to go wrong in the aorta, are you looking for the blood pressure to be high or low? High or low?
In terms of what we're trying to do?
When you assess a patient and you find somebody with chest pain, let's say it's tearing pain going through to their back. They read the textbook. They know what they're supposed to present with. I've got long-term high blood pressure. My dad died of an aortic aneurysm. I have pain that goes through to my back, and it feels like something is tearing. And you are going to get a blood pressure. What is your expectation?
High.
It's going to be very high. And that's why I bring this up. In dealing with this, your pressure sensors are laid out in such a way in the aorta that when things begin to go wrong, it says, I want more pressure. Just like a guy standing at the end of the hose off the engine who is saying, I need more pressure, I need more pressure. And the guy that's running the pump says, but my gauge says that you're doing just fine. And you're like, no, give me more pressure. And that's essentially the feedback that you get from the blood vessels. When somebody is having a stroke and some part of their brain is not getting enough blood flow, what typically happens first? It's asking for more what? More pressure, and more oxygen and more pressure. And so you'll find people with acute strokes, particularly bleeding strokes, that their pressures are running very high. If you have somebody with symptoms, from essentially their jaw to their belly button, and their pressure is very high, what that tells you is I need to at least think through their aorta. Wonder if something is going haywire there. And a typical story again is high blood pressure for some time, and occasionally it's in young people with certain diseases, and oftentimes they'll have unequal pulses from side to side. And that's one you don't want to miss, because that's not a Southview call. Those have got to go to the right place for the aorta to be managed quickly. And so you go to a cardiovascular hospital. That's it on kind of the blood vessels. Everybody okay with that? Understand? I will say, if you have somebody with abdominal pain and they knew they had an aneurysm and now their blood pressure is 60/40, what are you thinking they have? They've ruptured it. And again, it's going to a cardiovascular center for help. Yes, sir.
At another place that I've worked in the past, we were always instructed, and per our protocol, we had a standalone protocol, that if we had anybody that had chest pain, we always inquired about family history of aortic dissection or any sort of abnormalities there. Is there any teeth to that argument? Because anytime somebody had family history, we were required to take them somewhere where they could open up the chest as well.
Yeah. So if you couldn't hear that over the horn, the question was about asking as part of the protocol for family history of aortic problems, particularly aneurysms. And if they had any positive history to that, along with whatever else was going on, like chest pain, then they were taken to one of the hospitals who could take care of that emergency, and that's a great idea. Sometimes they'll be upfront enough to tell you, hey, I'm concerned, and the reason I called you is because I'm down here at the south part of the township, and they told me I need to go to Kettering, but I'm concerned I'm too sick to be able to drive there myself. But I have a need to go there because they think I have an aneurysm, or that's part of my family history, etc. What are the weird patients that have aortic aneurysms that you need to think through? Anybody know? Young people who get aortic aneurysms? Marfan's. If you ever think of the really tall, skinny people who have joints that can flex all the way back, their blood vessels are oftentimes very poorly put together. On the morning of the inauguration of President Obama, at about 4 in the morning as we're setting up for the inauguration day, there's a 28-year-old woman who goes down in cardiac arrest. We get her back. No reason that a 28-year-old should have an arrest. She's 6'3", 6'4", and very gangly, and the crews knew that she was really very loosely put together. Her joints were very loose. They decided to take her to the right hospital, and they spent the whole day in the OR with her, trying to repair her aorta. I knew about it because that meant the #1 hospital inside the perimeter, their #1 operating room crew was down for the entire day. It caused a few people to sweat a little bit. And you won't forget once you've seen one of these cases what can happen. There's also stars, TV stars maybe, that have had aortic aneurysms that they missed because they weren't thinking, when somebody says, hey, I got pain going through to my back, they weren't thinking about it. And the other people who get these are weightlifters who are exerting at a very high level. They'll stretch their aortas. Okay, so aortas and blood vessels, we okay with that? I'll move on. All right, compromised perfusion is what we're talking about. And the ultimate compromised perfusion is when something's not working. And if either the pump or the wiring doesn't work, then the disease is called cardiac arrest, and we have a chain of survival. Cardiac arrest can result either because of plumbing problems or wiring problems. And a very early job we have is to figure out which one it is and try to correct it immediately. Let me start first by saying children are different. And in this area, children are not little adults. So what do we know about arrest in a child? Typical cause is respiratory, and we don't do any of the things that we do with adults. So we begin by bagging them and oxygenating them and doing compressions on their chest. We may find them in asystole, and we're still not disturbed about that because we move ahead and we give them epi early on to try to get their heart to start a little bit. And we always think about respiratory causes in kids. So arrest in kids, thinking respiratory first. Rarely are we defibrillating or pacing a child. That doesn't happen. So kids, that's one special class of cardiac arrest. But let's go to adults. And when we think through adults and cardiac arrest, what are the most important things that we do?
CPR.
Good quality chest compressions, don't come off the chest. And look for an opportunity to give them electricity. That's how you should think about it. I'm looking for any opportunity to give them electricity because that typically is what's going to save their life. Typically that means defibrillation or cardioversion. Occasionally it means pacing. All right. So when the wiring is dead or has completely short-circuited, we're looking for opportunities to turn that around. That's a much easier thing than if the pump isn't working. So CPR. Ventilation without hyperventilating, airway not important to begin with, shock whenever you can. So here's the model that has been created across the country. So beginning in NASCAR country, so the guys in Raleigh, and then followed by the guys and gals in Austin, they began what they called pit crew CPR, which means who is in charge of a cardiac arrest patient? The BLS providers or the ALS providers? The model says it's the BLS providers. So I can't point to you guys who are following this electronically, but the model of CPR here has, in the diamond right around the patient, has 3 people. The idea is that 3 BLS providers take the critical roles of doing chest compressions, activating the AED, and then doing something at the head in terms of either just providing passive oxygen or bagging them slowly and preventing them from puking and aspirating, that they are the most critical roles in a cardiac arrest patient. In their model, they have the paramedic working around those 3, applying a manual defibrillator, starting an IV and getting ready to give drugs, and finally about 10 to 15 minutes in, after you've gone through a couple rounds of compressions, then it's time to think about an airway intervention. The role of the person doing compressions is not to come off the chest until they're getting tired. So traditionally in pit crew CPR, those 3 people are rotating, and every 200 compressions they change compressors. And so that's the classic presentation of pit crew CPR. And when it is done, it works very, very effectively for patients who have a resuscitation capability. Airway strategies, really important. The new models of CPR say the person will get plenty of oxygen if you just put a mask on their face and crank it at 10 or 12 liters. And if their airway is not obstructed, so put an OPA in, and an OPA includes an eye gel. The newer version and studies on cardiac arrest patients say that supraglottic devices, King Airways, LMAs, combi tubes, do not help and may significantly hurt cardiac arrest patients. Why is that? Because you're putting a device in that has a big blow-up balloon. It does a couple things. Number one, it directs any puke right into their lungs. Number two, inflating it decreases carotid flow up and jugular flow down, and therefore significantly reduces blood flow to the brain. And so their opinion is that supraglottic devices should never be used, and that only OPAs and then moving to endotracheal tubes. That's a little different, huh? And it has been the teaching for some time that you could just throw, a King Airway or an LMA or a combi tube down, and then the paramedic doesn't have to worry about that anymore. But it is very likely that that is harming the patient. What is the other intervention that is beginning to be studied in terms of getting more blood flow to the head? Raising the head up or lowering the head down? Anybody watching the literature? It's head up. It's head up. And what they're doing in really good studies now is if they elevate the head about 20 degrees and leave the person flexed, that it dramatically improves blood flow out of the brain so that the brain is accepting fresh new blood going in and keeping it alive for longer. And so putting a thumper on and then raising the torso up 20 degrees is what they're studying now in Memphis and St. Paul and a couple of other places. And so far they're getting good results. Don't be surprised. What happens when you lower the head? Do you think that improves brain flow? It dramatically decreases it, because essentially it engorges the brain in old blood, and it's very hard to get new blood in. So it's very clear that the thing not to do is to lower their head. And it may be in the future that we're going to get people on a board with a compression device, raise their torso, endotracheal intubation, and then following end-tidal CO2s is the way we will be doing resuscitations in the near future. I want to make you all aware of that, because it's going to feel a little bit different. All right, why do I talk about end-tidal CO2? Because, again, that tells you whether the engine is working or not. If the engine's not working, what's the end-tidal reading? High or low? It's extraordinarily low. And it gives you the ultimate read about what's going on with the patient. So an end-tidal CO2 below 5, and typically it's, has anybody ever seen a patient that was running at 2, 3, 4 for any time? I've never seen it. They're either 0 or they're running, above 10 or 20. And so there's really not very much gap. But by the data so far that we have, if it's less than 5, it means the engine's dead. You can do anything you want. You're not going to get those people back. So, drugs. How about drugs for cardiac arrest? Yes, sir.
Going back to that last slide, can you explain what the ET is best option at 10-15 minutes, what that's about?
Yeah. Who's asking?
Station 44 is Zacharias.
Okay. Hi, sir. Okay. What that means is the BLS crew, just the model is, the first arriving crew gets to work doing compressions, bagging the patient, keeping them from aspirating, putting in an oropharyngeal airway. The paramedic starts an IV, gives a first round of drugs. They've given some shocks, hopefully. And about 10 to 15 minutes in, the paramedic says, got my hands free, now it's time to do something with the airway. The current literature says don't put a supraglottic device in, put an endotracheal tube in. And the usual time interval when you're ready to do that is about 10 to 15 minutes into your time at the scene. And then the option is endotracheal intubation, and then apply the end-tidal CO2. And then it's giving you a really good read on how well your compressions are working. And then at that point, you're going to think about a Lucas device, et cetera, and a few other interventions that we're going to do. Ben, does that make sense?
Yeah, so, but for us here, where we have multiple medics, we're not waiting 10 to 15 minutes to put an airway.
You don't have to. Although it is always best.
I wasn't sure that wasn't something new.
Yeah, it is always best if you can manage this patient without putting an endotracheal tube in. So frankly, your attention at the beginning is on doing good compressions, looking for an opportunity to get the patient back on their own, which is typically doing electrical shocks and getting them back. and then never having to intubate them. Because not having to intubate them is a really good thing too, correct? That's right. That's the answer. It's not having to intubate them. So for us, yes, if we have multiple medics, everything's going well on the initial set of interventions, and you have somebody who's ready to put a tube in, go ahead and do that. Okay? Make sense? Thanks for asking. All right, cardiac arrest drugs. By the numbers, just so you know, every study that's looked at cardiac arrest drugs, it says they don't work. It says they don't work. And it is because the studies all give them the drugs too late, they're in asystole, and now you're trying to rescue them. For now, our protocols say very clearly that epinephrine goes early, and that is still probably the right answer. If you're going to get anything out of the heart, you kick the heart. Epi is the ultimate drug to kick the heart and make it work. Also, if there's a couple other reasons for arrest, like they're in anaphylaxis, or they have had another cause to shock, another cause of them being in shock, epinephrine is our ultimate drug. So epi early is still a good answer. There is no support for vasopressin for those of you who've heard that. Lidocaine is still our best antiarrhythmic drug, not amiodarone. And so lidocaine is still good, particularly for patients who come out of a VFib or VTAC cardiac arrest. And as many of you know, bicarb is still really good, particularly for a poisoned heart. If you think about a poisoned heart, being too much acid, too much potassium, too much of certain drugs, or hypoxia like in a drowning victim, that bicarb is still a very good drug in cardiac arrest patients who have those potential causes. Let me finish this up and to put it all together. So a cardiac arrest, an ideal cardiac arrest. Bystander CPR and an AED on before we get there. But when we get there, AED, compressions, pit crew style, oxygen by mask, and an oropharyngeal airway. If there's somebody who has a bag valve mask, go ahead and slowly, about a breath every 10 seconds, so about 6 breaths a minute at low pressure so that you don't force a bunch of air into the stomach. The airway person does not let the person puke and aspirate. So if they're empty in their stomach, they're sweeping it or suctioning it out. You look for opportunities to shock. An IV gets started. You start with epi, airway by endotracheal tube and end-tidal CO2. And then with the end-tidal CO2 under 5, you're looking at things that aren't going very well, trying to do some rescue stuff, but very, very appropriately, you're looking for opportunities to terminate resuscitation. So then you're reporting to the online medical control physician, unresponsive patient in asystole with end-tidal of 0 and continued asystole unresponsive. That's 3 reasons for termination of resuscitation. You guys know as well as I do, there's times when you can't terminate in the field. You're not at the right physical location. You can't stop on somebody in the middle of a restaurant, that kind of stuff. So sometimes you got to move it somewhere else. This is time where you're considering whether to put on one of our squeezer devices. And so if you are at the point where you're getting good results with high end-tidal CO2s, you're making a decision where to transport and how to transport safely. There are some patients who fit in our squeezer devices. There are some patients that don't. The most dangerous time for a cardiac arrest patient is when you're trying to move them around with the device in place and get them into a medic unit. Just so you know, that's where a lot of people get into big trouble. The squeezer device or the thumper device does not know the difference between clavicles, sternums, livers, stomachs, okay? And if that device moves, you are toasting the patient, just so you know. And there are some people who are too big or too little to fit safely into the device. I want to remind you of that. We've had some really unfortunate deaths that resulted from the device slipping, moving, being placed too low, and taking the liver out completely. There was a case recently of a very viable patient who had slipped down over their stomach. Their stomach was inflated with air from bystander CPR. It ruptured the stomach. They got them to the hospital. They got a pulse back, but their stomach is, their whole abdomen is just inflating. They took a needle and decompressed the stomach, which then resulted in pulses coming back. but a completely ruptured stomach from the device having slid down over an already full of air stomach. How's that? So we got to be careful with the Lucas devices and our other squeezers. Fair enough? Everybody understand that? All right, and then transporting. So we make good decisions, and this is just like your decision about going to a trauma center or a burn center. If we think that this is a very viable patient who will need to go, therefore, once they get into the ED, they're going to be heading upstairs to the cath lab or one of the other intervention places. Please think about investing 10 or 15 minutes in transport to one of those places as opposed to one of our closer centers, which may not have those capabilities. Then they're trying to stabilize the patient here and prepare them for transfer to one of the other places. That's not as good a use of time for the cardiac arrest patient as we would like. Fair enough? Everybody understand what I'm saying? So all good things can happen when we have end-tidal CO2s that are high. Any good cases locally of long CPR that resulted in good outcomes for the patient? Anybody familiar with those? What's the longest you guys are aware of that somebody's had CPR ongoing and had a good outcome?
I think we had one that we took from right on Cloud Road over to Miami Valley South, and he was on a Lucas device and he resuscitated for about an hour.
60 minutes?
Oh, at least.
And a good outcome? Yeah. So 75 minutes is the really good cases that I have been aware of. There was the soccer player in England who went down on the pitch. They're doing CPR on the soccer field. And they did 75 minutes total of CPR on him. And the next day, he's on ESPN thanking the people who did chest compressions. They were guided by really good end-tidal CO2s. He had a wiring problem in a very sophisticated, hypertrophic sports heart, okay? And his wiring came undone and he went into asystole. And they rewired him after 75 minutes of CPR, and he's talking about getting back on the pitch. How's that? There was a local case that we featured from Akron, Ohio, where a clerk from the hospital walked out after the end of her shift and collapsed in the garage, in the parking garage of the hospital. Bystander CPR, get her in. They did 75 minutes of CPR on her and took her up to the cath lab. They found a valve problem that had never been noticed in her before, got her back, and at the Star of Life ceremony, she wanted to thank everybody who did 75 minutes of CPR on her to keep her alive. So there are cases, always guided, and the people who came to talk about the case, yeah, she had end-tidals in the 30s the whole time we were doing CPR on her. And so we knew we were doing the right thing. Her brain's still getting perfused. All the cells are still working. And we had to get the cath set up ready to go for her to do the intervention. They put a bypass machine on and got her back with a great outcome, again, within 24 hours. So transporting to the cardiac centers, high efficiency. And then at the end of the cardiac arrest, if you're getting people back, I just want to remind you that's the time for lidocaine drips and other things. Don't let them die on you again. How about starting cooling in the field? Is that a good idea? What have they found?
You can't maintain the cool temperature.
Yeah, it's very hard. More importantly for us, they've already been dead. Their heart is still really pissed, okay? And you start throwing cold ice water saline into them and the heart goes back into VFib again. What they still believe is that at some point later in the resuscitation, cooling the brain may be a good thing to do. They're not getting nearly the results that they did at the beginning. I don't want anybody to think we're shortchanging our cardiac arrest patients by not cooling them right away, because the reality is when we try to cool them too quickly, their heart goes back into whatever rhythm, and then you're back doing CPR again. And so there is probably a place and time for cooling them, but it is not in the field. Okay? All right, so I'm going to go through a couple more cardiac things, and then we'll take a break. Is that okay? All right. Are the other things that can go wrong in the heart? It's going too slow, it's going too fast, it's going irregularly. And for any of these things, our key is, how's the patient doing? What are they telling me? Augustine's rules are there are 3 things to do for people who aren't perfusing correctly. You can give them supportive care, chemicals, or electricity. The very hard decision is between chemicals and electricity. And so Augustine's law says if they don't refuse electricity, they need it. All right, so we'll go through that. There is somebody maybe even running around in the station here today who's got a heart rate of 30. Heart rate of 30. Sir, your heart rate's 30. Yeah, it's 30. I called you here. What did you call us here for today? I have a cut on my finger. I need some cut on my finger. You okay?
Yeah.
And I say, well, sir, your pulse rate is 30. I don't like that number. And he says to me, I don't care what you like or don't like. I'm running around in 30 all the time, and I'm just fine. Will you take care of my finger? Well, my protocol says that I'm supposed to do something for you. And he says, will you stop? I'm fine. Take care of my finger. Is that right for bradycardias? We have tons of bradycardias that we can't write protocols for because they're doing just fine. Sir, I am going to put these pads on you because I don't like your number. They're going to shock you 70 times a minute to go like that. Is that okay with you, sir? Well, hell no, it's not okay with me. Don't even think of it. Well, I'll give you some Versed. It'll make it better. Is that the right thing to do for him? It is not. Okay? So in the role of perfusion is good or not, the lieutenant says, I'm fine at 30, or I don't feel very good, but you certainly are not going to shock me at 70 times per minute. So at the very most, if I'm chest pain, short of breath, I don't feel very good, but you're not going to shock me 70 times a minute, sir. That ain't going to happen. I'm giving him some chemicals, and our chemicals are atropine and maybe epi. Okay? So Augustine's law says he refused the electricity, and so he doesn't need it. All right? If it's too fast, there's maybe even one of you who's out at a fire scene after you did your drink at 5 o'clock, and then we got a working fire. Your pulse rate's 170. Let's just imagine, and you say, I'm fine. Let me go fight some fire. Your number says it's outside our protocol. You're at 170. Yeah, that's what happens. I take my drink, and my heart rate goes up, and I get a better workout in, whether it's in the gym at the station or out here on a working scene. I don't like that. I'm going to shock you. How's that? I'm going to put some pads on your chest and give you a big zap at 200. It'll jolt you right off the floor. What do you think about that, sir? Ain't going to happen. Does he need chemicals? Little adenosine? Little? No. Do I have something for that?
No.
No, he needs nothing. Over time, he'll slow down a little bit. And so if we're running too fast, and here's how we run too fast. We have regular fast rates. We have irregular fast rates. Narrow and wide complex. So we have the 4 boxes there. We have to put them on a 3-lead monitor, take a look. But more importantly, ask the patient, what's going on with you? How do you feel? So here is, I'll point at you again. Here he is. I did call you because I don't feel good. And my heart rate is running really fast, and it's making me feel a little short of breath and very, very anxious, and I don't like this at all. All right, sir, we want to put these pads on your chest and shock you. Is that okay with you? Hell no, don't do that. I know they have medicine. The first dose never works. They always have to go to the higher dose. What do we do?
Go to the higher dose.
Go to the higher dose right away. And what does he know that he has? I've got SVT. I even have a name for it. I have tried what already myself? He's tried to vagal himself, which is what all of these people, they don't want to have anything to do with you. They don't want their night ruined. They don't want to go to the hospital and spend a couple hours there. And so they try to vagal. What are the vagal things that they will try to do? Bear down, rub their eyes, rub their carotids, rub their belly. They'll try to breathe through a straw or push through a straw. The most important of the vagal maneuvers and the most effective is what? If you're at home with SVT, what do you do to try to break SVT? What works more effectively than any other vagal maneuver? Dunking your face in ice water. Okay? Not tapping ice water on your face, putting cold rags on your face. This is literally dunking your face in ice water. That is a very effective vagal maneuver. Make sure you have somebody there to catch you, because some people's heart rates will go so low and I think all of you have had the occurrence of dunking yourself in cold water and something disappears in the male species immediately and you get really lightheaded. And that I get very vagal when I dunk my face in cold water. Anyway, if you're really looking for a vagal maneuver, remember they may be wet around their face and you're like, are you sweaty? Like that? No. I tried to dunk my face in ice water and I was told that worked best. And I Googled it. Dr. Google said, dunk your face in ice water, and it still didn't work. So for the EMTs, we give them a magic drug. For the paramedics, what's the effect of the magic drug for these kind of patients? What is it to produce? Asystole. It produces chemical asystole. So you warn the patient, you warn the EMTs, you look away from the monitor for a minute because if it works correctly, it produces asystole, and then some squiggly lines, and then hopefully they come back, oh, thank you, I feel much better. I don't want to go to the hospital. That's the next argument, right? Right? Okay, let's say we get a report of a person down. You get there, this shows about 170, but let's say it's 220, and you feel a pulse, it's really, really thready. You try to get a pressure, you can't get a good one. What does he need? Sir, we're going to put pads on your chest. We're going to shock you with 200 joules. You're going to flop off the floor. What do you think about that? He's laying unconscious. What does he need?
Electricity.
So he passed Augustine's law. He didn't resist the electricity, so he needs it. And so you occasionally will run across an SVT that needs electricity. All right, how about this patient? So they're running fast. They're irregular. They've had it before. Do we have magic medicine for them? We do not. So this is really important. Does adenosine work for rapid atrial fibrillation? No. It does not work. It's a waste of your time and energy and money. And these people get another drug. So for your ACLS, you need to remember diltiazem is the drug that says 170, 160, 150, and it goes down slowly. That's the effect of diltiazem. And the patients typically aren't having big symptoms. They require some supportive care with some oxygen, etc. All right, so PVCs. These important things? Is there somebody running around in the station right now with these? Probably is. Do they need any treatment? Probably not. They should know that they have them. We used to chase these. My early days was chasing PVCs. You'd sit there with a vial of lidocaine and wait for a PVC and give them some lidocaine every PVC. What if you run the PVCs together? Good or bad? Bad. Typically not a good thing. There are still people who run around in VTAC though, and they will tell you, just like he did, hey, they've told me my heart goes into this fast rhythm and I feel fine. Will you take care of my cut finger? Well, you're in VTAC. I know. I have a history of that. My cousin used to be that way. He lived here. And he had mitral valve prolapse, and when his valve was prolapsing, he'd be in VTAC walking around, exercising, doing whatever he wanted to do. So they're stable, very stable VTACs. There are stables that don't feel good. So we go to you, and I don't feel good, I'm gray, I'm short of breath, I'm sweaty. You pick up rhythms like this. Do you know what VTAC is? Never heard of it. Do you have a heart history? No, I don't. Let's go ahead and treat those. And the treatment for those is lidocaine. Sir, we're going to put these pads on your chest and shock you because I don't like that. What do you think about that? Ain't going to happen. So he failed the rule. We're not going to shock him right now, but the pads are going to be in place for somebody like that. And if we do get to shocking, it's cardioversion. Right? So there's VFib, and because somebody always asks about torsade, we have to remember if it's a torsade, VTAC, VFib, that we have to give them some magnesium. Otherwise, lidocaine is a very good drug. Cardioversion is pushing one more button on the machine. PEA. What is PEA? What is PEA in regard to wiring and pumps? PEA says wiring's working well. Pump ain't working. Just like the guy at the end of the nozzle out here who tells the pump operator, I got no water. Pump operator says, the wiring's working. I hear the pump, it's working well. Damn you, why don't you just accept the fact that water's coming through the end of your nozzle? It ain't working. So what do we have to do? Find out why the pump isn't working. Sometimes the pump is bad. Sometimes the pump is poisoned. Sometimes the pump can't get anything in, it's vapor locked. Sometimes there isn't anything to go in the pump. Then we have a volume problem. And then we have to work through what is known here as the H's and T's. Occasionally you have to put a needle in something. Occasionally you have to give them drugs. Typically drugs are the only thing that will help them. Asystole, good or bad?
Bad.
Only good in drownings, in pediatrics, and hypothermias. And otherwise, you know, the expectation is very quickly run through our protocols, good quality CPR, see if we can find something that looks like fine defib and shock them, all right? And otherwise, it's a termination of resuscitation candidate. Yes, sir.
What are your thoughts on using PEEP devices
For
in relation to drownings?
Yeah, PEEP is fine once you get to the point where you've stabilized them enough to do that. What you don't want to do with PEEP is induce a pneumothorax. And that's one of the risks when you begin pressurizing the airway, is that you'll induce a pneumothorax. Their lungs already been insulted. If you will, some parts of it are maybe full of fluid and other parts are not. And so preferentially, if you're putting higher pressures in, it's going to the sides that are that still have more air in them than water, in which case sometimes you'll rupture them. So that's the risk there. And then I thought you were going to ask about plunger devices, which seem like they should work. They keep putting them back on the market and telling you if you put a plunger on the chest and are doing compression so that you press down and then when you release it sucks the chest out, sucking blood into the chest so that the next time you push down more blood goes out. They still haven't found those work. So it's theoretically, and they have the guy who keeps doing the toilet plunger, you know, and saying this works, this should work. And so far, statistically, it hasn't worked at all. So there's some of these new devices that supposedly...
I mean, that goes against the argument of trying to keep negative pressure on your chest, because now all the CPR is telling you don't take your hands off the chest, take it to a neutral position, so you're keeping just a little bit of that negative pressure in there.
Right.
So,
Yeah, so the negative pressure has to be there to draw blood back in. And realize that's what you do every time you take a breath. You're creating negative pressure, you're accentuating flow back in so that your heart can push good blood back out. All right, pacing, I just want you to remember there are two settings for the pacemaker, rate and how much juice. If you have a conscious patient, what do you do with the juice? You have a patient who's kind of semi-conscious with you, running really, really slow, not like him. You start low and go higher. If you have what is close to asystole unconscious, you start at max and then turn the juice down once you've got the caption. All right, high blood pressure, I just want to remind you, do we treat high blood pressure in the field? We do not. Is it dangerous to do that? For the reasons I talked about before. Typically, if the person's brain and other organs are asking for more pressure, we shouldn't mess with that. And a really difficult thing for us to deal with is, I don't like that number on your blood pressure. Here, I'm going to do something about it. And the next thing you're like, he can't move his right side. His brain was asking for more pressure by you throwing nitro at him or doing something else to lower his blood pressure. You induce a stroke. That's a really bad feeling. All right. For our maxed out patients on meth and other things, what is the treatment for very elevated blood pressure? Just a reminder. It's not nitroglycerin, it's benzos. Okay, so you give them more and more Versed. I'm going to talk more about congestive heart failure later. Okay, bottom line, good, we have more cardiac patients. Means we're keeping them alive. Good, they have more devices on to keep them alive and in good health and functional in the community. Really hard for us, though, to give you a single set of symptoms to look for, because people just don't present the way that they're supposed to in terms of chest pain, shortness of breath, palpitations, and other things. And so we have to be very smart about using our tools anyway. And so bottom line, we are making street physicians available. So we're going to take a 5-minute break now and come back and do pulmonary emergencies. Is that okay, everybody? And if there's any questions from the other stations, if you want to send them through, I'll try to answer them as we get started, okay? 5 minutes.
there's this coffee up there.
if I haven't done that.
Of course.
It's okay. Keeps us from eating all of them.
I've already had one.
It was quality testing, right?
Absolutely, yeah, that's it.
You know that as part of the educational process, these are calorie-free.
Right.
And so anything that's part of education is calorie neutral. How's your eye?
Fine.
No, it's not. Did you see it's right eye?
I had something in it this morning. It doesn't bother me right now.
Your finger was in it.
Yeah, I know. Ever since I got here. No, I felt like an eyelash was stuck in it this morning.
Making everyone else start to water.
I just flushed it with all that and put a compress on it. And we went to the store and we just got back.
Cocoa?
Thank you. Have they changed anything in that bag over the last week, Chief?
Am I to assume they can all hear okay and see okay?
Yeah, I've been texting with them, making sure.
I haven't even used it yet.
Really?
Up to tomorrow. I'm on it.
I got started getting all the feedback from the cot, and instead of giving me feedback on the cot, they just bitched about it. It needs to have a load system. That wasn't the point of the evaluation. You were evaluating the cot.
I mean, it's definitely quicker.
How's everything going?
It's lighter.
Good. I'm actually, funny that you're doing this, I'm going to DC on
I had to give them a call about
October
it.
2nd and 3rd to meet with the newly installed.
People were, they had some people
President
said,
Chief
and I think it's
Ludwig,
just because they're
Auto Draws,
Basically, I said, it's heavier.
a representative from
It's not.
It's literally the same way.
one of the major
Like I said, they've shifted the weight.
healthcare organizations. I cannot think of it. It starts with a three-letter acronym, so it's not even so. But either way, meeting with them for a new initiative called If You Feel Something, Say Something.
Mm-hmm.
So for cardiac emergencies and firefighters, so we're meeting to start working on that initiative and start trying to push it out to the fire departments. There's been 3, including actually 4 now with the FDNY lieutenant that passed away directly after a structure fire. So basically they've shown the prevalence of firefighters showing back up to the firehouse after some sort of event. People have heard them make the statement, I just don't feel very well, and then they die within 24 hours. So since they met, I'm filling in for another one of the board members who's having a baby, so he can't be there. But since they met at FRI, there's been 4 firefighter fatalities that have been linked to people saying I don't feel very well and then passing away within 24 hours. So.
And that's full-time.
Yeah, exactly. How many volunteers, how many part-time, how many people that weren't documented, how many people got back to the firehouse and were by themselves and said the same thing to themselves, but there was nobody there to hear it. So obviously it's become a pretty big epidemic in the fire service. And I used, whenever I was telling Chief I was going to be going to do that, I used, and I doubt that he'd be annoyed with me for using his name, so I would use his name anyway. The guy, he's a captain for City of Franklin, Chad Reed, who was my partner in Liberty for a long time. We got back from a MVA and we were sitting down for lunch and he looked about the same color as a sheet of paper. And there were 5 of us sitting there. It's like, dude, you look absolutely terrible. Like, I feel like shit. It's like, let's go put you on the monitor. He's like, no, I'm fine. He sat there, tried to eat a little bit, still felt like crap. Finally looked at our captain and was sitting at the table as well. He's like, hey, I'm taking off. I'm going to go home. And we're all like, let us walk out to the medic unit. Still didn't let us. Called his wife on the way home. He lived in Franklin. He left Liberty, drove home, got to his house, and his wife had come home from work. She worked in Franklin as well at the bank. Said he looked like crap and taken him to the firehouse. Took him to Franklin's firehouse that he was having stinting. So ended up transporting him. So I mean, Chad Reed. So I mean, perfect example. I've lived through having somebody indignant about not going to the hospital or even just getting 12 leads. Like, we're sitting here, we have all this technology. Just let us do it.
Look at, what's his name? Worked at Coleraine.
Tim Beach.
Yeah, literally was mowing his lawn. He's like, I don't feel right. Went to the hospital. And
43 years old,
massive
cabbage.
He just knew that he didn't feel good, and
So,
But we have to worry about how we
Yeah,
receive
he
those
was
messages. When
moments
somebody
away.
doesn't feel good, it's not, oh, you're a wimp.
no. it's-
Suck it up. You know,
Let's
it's
go.
hot for
We have-
all of us.
literally,
We had, and again, I think it's like any of the
Gone.
PTSD and any of the other stuff as well.
I'm like,
There's a
fuck
decent-
yeah. I
decent
told Liz, I-
inflation.
They did that quick with me.
Like crap, you probably feel like
damn.
crap. If we go out and put you on a cold leave and there's nothing there, fantastic.
It is
Go
nice.
home because you feel like crap, or stay here and hopefully feel better. But worst case scenario, we go out there and we catch something and we can transport you right now.
Yeah, and it's not always just a stomach, it's, you're pale because you're bleeding.
Yeah.
Well, I've been in the bathroom and it's really smelly, black tarry stuff.
PT waves, major dehydration, something that could
Yeah.
lead to something later on. I mean, we can catch multiple things that we're educated to identify. Again, we have this bravado that comes about that people
It's dangerous.
don't want help.
They go there like 6 times a day. I hear that all the time.
Hey, you got a sex offender in the neighborhood.
we do.
Over by my house. right where my son hangs out with his friends. Fences are 20 years old. I'll probably put one today. Lake 44 doesn't have one now, which is, as of yesterday.
Oh, but all the other.
All the others do.
Nice.
Matt and Chris gonna be gone.
Yeah, they made a run. They had
And I'm down
Double
like
cane,
Maine,
yeah.
like right across the street.
Okay.
There's some-
Tell me when you want me to restart, Chief.
We're good to go.
You good to go?
Yeah.
All right, for the stations, we're back up, and we're going to, since we pair so nicely, this is the pulmonary side, the I can't breathe side of the presentation. So I will let your next patient be this kid that's on the screen. Anybody's sphincter tone tightened just a tad bit?
one of the kids tripoding.
Yeah, the kid's tripoding and looks blue, and that's the very last patient you want to have to take care of today. So, causes of I can't breathe. Well, there's a bunch.
Allergic reaction.
Yeah. Lungs, airways, heart, clots, carbon monoxide, shock, stung by a bee, etc. And these are things that, again, are things that typically generate a higher sphincter tone in us. I always use this because one of the more famous cases from Chicago Fire is about the duty to respond. Do we have a duty to respond when we put a patch on and we say that we're a 911 responder? We do. One of the cases that they are not proud of, they got a short of breath call from a young lady. It goes out as a Delta call. They go to an apartment, knock on the door, nobody answers. They look in a window and don't see anybody in there and call the units in service. No patient found. Good thing? Okay. One of the other departments I work with had a fire call at 2 in the morning, smoke in the area. Engine pulls up, nobody gets out. They don't look in any of the houses. They say, yeah, there's just smoke smell in the area, we're back in service. 2 hours later, what happened? Lady's dead in her house that's on fire. It was on fire to begin with. A wreck in a not urban place. Driver extricated unconscious, taken to the hospital, clear the scene, get called back an hour later. What had they found? A second patient who'd been ejected from the car. None of those are things that departments could ever escape from. The guys in Troy, did they have a bad day? A couple years ago. Remove grandma, don't find the CO in the house, 3 kids don't show up for school the next day. Not good. So a reminder in any of these things. And short of breath calls what they didn't think through is that a short of breath call may have a patient who went unconscious, which is what happened to that girl the best they can tell. The family didn't find her a day later. The coroner says the time of death was the same hour that it was. A nice voice on the 911 radio, a very short of breath girl. It goes out as a Delta call. They didn't in any way do a diligent search to find her, and it was probably a very avoidable death. She was an asthma death. So, airway procedures are really good, and I want to remind you, tracheostomies, another much more common device. Who knows more about the tracheostomy, you or the patient? Yeah, the patient always knows more, and typically you are just there. They like your bright, shiny uniform and your smiling face, but what they really want is something that you have in your bag that they don't have right that minute. And they have broken something, they've dislodged something, they are missing their saline, they're missing a clean suction catheter, etc. And so a reminder, trach patients can make you very, very sphincter tightened. And so I will remind you most of the time when you walk in, you ask the patient, why are we here today? I'm having trouble. My tracheostomy cracked. I lost a piece of something. I don't have any saline and I can't clear myself. I need saline and a suction catheter. What can I do to help you is the question that comes out. Is the question that comes out of your mouth, and in general you're there to support them. So tracheostomy is not something you have to be afraid of. This is somebody who had a short of breath problem. I'm just showing you a picture from this county of somebody who took their motorcycle through a wire fence. Is that a good thing? So the upper hole is what was created by the wire fence. The lower hole was what was created trying to rescue them to put an airway back in. The trachea is a relatively simple little tube. And a couple years ago when we were in this room looking at the pig tracheas, everybody got really comfortable that, yeah, I can do interventions on this thing. It's not that complicated. It's just a tube. Okay, why do we intubate people? Well, there's a couple reasons. They're obstructed, they can't oxygenate, they can't protect, they can't manage their secretions. These little ones need tubes. So this was my old-time photo here. 2 kids being pulled out of a house fire, unconscious, not breathing. Why do they need tubes?
Swelling of their airway.
Okay? They are typically obstructed or going to be obstructed. They're not oxygenating well. They cannot protect, and they can't manage all the frothy black stuff that's secretions. And eventually they're going to puke. And so those are all of the things that are an element. So this was my old pictures, but what happened a couple weeks ago that allowed me to put new pictures in? Everybody see these?
4 of them.
There were 4. Okay, 1 and 2 and 3 and another picture of her. And then what's the good picture of this series? Is this one. So she was the last to be removed. She was the oldest of the children in that house. They went out on a big call. They'd go out on a fire with 4 kids trapped. Noon call. Smoke from a building. And they get there and begin to knock the fire down and realize there's 4 kids inside. Where's mom? The rest, she's not working, she's not there. There's some pictures in this series of mom coming back. I don't have them and I'm not going to have them. But you never know when these are going to happen. And there's a famous picture from Sydney fire of them carrying a kid out of a house, and they weren't expecting to find a child trapped in a house at that time of day. So the kid's unconscious, though, is a really good time for you to think immediate intubation is what we need to do. All right, let's talk about some other causes that are common for short of breath. All right, here's one of them. Could this happen to somebody in this firehouse? Young people, old people, this is indiscriminate. There's a number of reasons why people may have sticky blood, One of them is if they've immobilized something and they're not using it, not moving the venous blood out of it very quickly, and then they form a big clot in a vein somewhere, and then part of it breaks off and goes to their lungs. Typical symptoms are, I'm short of breath, I'm having some pain in my chest, but frequently these people, and especially in the younger ones, they have a syncopal episode. They have enough of a clot that it is occluding blood flow to their brain. And so you can't miss those. And these are typically, again, people who do not want to go to the hospital, and you kind of have to talk them into it. And you recognize that they have a splint on them, or they just had surgery for replacement of such and such. Are you on any thinners? No, I'm not. The doctors decided not to put me on them. It's a young woman who just got put on oral contraceptive pills that creates sticky blood. My last case of this is a very unfortunate one. It is a young man who came into the emergency department short of breath and had passed out. His shortness of breath had mostly resolved. He had what we would call stable vital signs. We do a blood test. These are very difficult things to find, even in the emergency department, and you have no chance of finding this in the field. Anyway, this young man had an abnormal blood test, and so we sent him over for a CAT scan of his chest looking for clot. That's the protocol in the emergency department. The patient goes over. I notice him going over. I notice that he's coming back, and with him coming back is the x-ray specialist, the radiologist, who said, I need to go over the results of the CT on the patient whose name, John Smith. They said, yeah, they're just wheeling him back over here. What's the matter? This kid is just full of clot in his lungs. And I'm wondering, is he unconscious? Is he near dead? Or what's going on with him, because his lungs are full of clot? I said, no, that's him right there wheeling into the room. He's sitting up, watching TV. His vitals are fine. His oxygen saturation is 97% at that moment, 97%. He said, this kid's full of clot. He pulls up the images on our computer, and he says, I can't believe this. We criticize you guys all the time for doing all these tests, but we realize all these people who have all this clot have very few symptoms. And so this kid is 28, no immobilization, no recent surgery. What's going on with you? Well, I just got short of breath, and my legs are fine. I don't have any swelling there, and then I passed out. So of all of the crazy things we think about in young men with clots that aren't supposed to be there, what did I examine next? Anybody know this story? I examine his testicles and find a mass. And what is the first test that I do on him? A pregnancy test, and it's positive. Why did I do that? Because testicular cancers in young men produce HCG and other hormones which make their blood very thick. And so when we see an unexpected young person, male, we think through testicular cancer, and that's what he had. So our job was first to find the clot, and then secondarily what would cause the clot. We got to figure that out. So for those of you, and we've had people in the fire service who've had unexpected clots, and the job then is to go find out why are they clotting, and what do we need to do with them the rest of their life to keep them from dying. We kept that kid from dying and did a really nice job of it for him. All right, respiratory failure, our next real problem. People poop out. In this township, this is typically pulmonary edema, congestive heart failure patient, and maybe COPD patients. They are typically in what position when you find them? They look tripod-y, or they're upright, and you try to lay them down. Is that a good thing to do? You're going to kill them. They will die. We've had people laid up over cars who said, I can't breathe, and I can't even sit down. You can put that stretcher behind me, I can't sit on it. What do we do for them? CPAP, a really good thing. So what is congestive heart failure about? I skipped it in the heart section because really it goes under the I'm short of breath presentations. What do they look like when you see them originally? They look like the Michelin Man, right? They're puffy everywhere, particularly in their lower extremities. They may tell you they've gained weight. They may tell you it's Labor Day and everybody was over and we had beans and ham, but I didn't add any salt to anything. Is that going to save them? So beans and ham and potato chips, and now I can't breathe tonight. And now I'm sitting upright in bed and I feel terrible, and I got on the scale and I'm up 10 pounds, and don't try to lay me down. Fair enough? So do we still have treatments for them? And you got to it right away, which is CPAP. And that's what we had to do for this guy whose pressure was 250 over 170. He's laid up over the top of his car. He's trying to drive himself to the hospital here, and he ain't going to get there. And where did we end up transporting him? Anybody want to think that through? We got him on CPAP and he felt better. We put him on the stretcher and he says, I still can't breathe, so how do we transport him? In the captain's seat, where he was much more comfortable. He gets to the hospital, and what does he tell us he wants to do in terms of one in the emergency department? He wants to walk in. Okay. You try to sit him on the stretcher. I ain't doing it. And that's just getting him worse. Do we have drugs for congestive heart failure? What is our only real effective drug in congestive failure? Nitroglycerin, which essentially expands the tank, gives them a place to put the fluid for a little bit out of their lungs so that they can breathe. And then ultimately we need to get the fluid off. That's typically what we need to do in congestive heart failure patients. Many of those people, in one of my famous cases, was on Clio Road. Somebody who was in pulmonary edema, coughing up pink sputum, unresponsive, sitting up, and we tubed him sitting up. It was one of our early cases of tubing people sitting up here. And it's easier to do sitting up than laying down. Convince yourself, go out in the medic sometime when you have some training time, and practice intubating a mannequin sitting up. In Atlanta, for training down there, we never, ever, ever had mannequins on a table and practice intubations that way. The mannequins were either sitting in a chair or laying on the ground, which is how we typically have to intubate people. And in our respiratory distress people, so that could be COPD, it could be pulmonary edema, you have to practice intubating, and you should be very comfortable. It's really easy. And we've intubated a lot of people in trauma situations sitting up, and you recognize the old uniforms here, and this was a simulation. But in trauma, you sometimes know for the trapped patient, you got to intubate them upright before you pull them out and they puke and fill everything with cheeseburgers and beer, and then you're trying to intubate through all that mess. No. Get them intubated before you get them down. Okay. All right. Other causes for respiratory distress: asthma, COPD, pneumonia. These are our common ones, right? Asthma is a disease of inhalation, exhalation, oxygenation. It's exhalation. It's a disease of exhalation. And so we gear all of our therapy towards making it easier for the patient to breathe out. And the drug that we have that does that most readily is albuterol. We mix it with some atropine and we call it Duaneb. Only one dose of that works, otherwise it's just risking complications. Albuterol works real well. If albuterol is not working well enough, or if you had that kid who was tripoding already, what is your finger on in the drug box? Epi. Epi. This is the time of year to think about that. And epi, we talked about it in cardiac patients already, and it kicking the heart. For your short of breath patients, it's the ultimate weapon for people who aren't moving air to begin with. Therefore, giving them albuterol into an airway that's not moving air is not a good exercise. So you got to do something delivered a different way. So epi, and the only way we give epi now is IM or sub-Q. It's always IM now. We have no sub-Q left. And let's talk about anaphylaxis patients. Anaphylaxis, since we're at that time of the year, and there are actually a few bees around this year, which is a good thing. Does Benadryl treat anaphylaxis? Let's start there. Is Benadryl a treatment for anaphylaxis? It is not. It is not. Don't ever think that either Benadryl or Solumedrol treats anaphylaxis. The only drug that treats anaphylaxis is epi. The only way to give it is IM. And do we want to give it early or late? Early. Always early. Don't wait for the patient to go down the tubes. And there is no excuse for us failing to give people epi early on if we think an allergic reaction is the problem. And typically, once we've gotten the call, that's it. Why do people not have their own epi anymore? It is too expensive, and frankly, it's not available. And right now, another thing running through the arena is the shortage of EpiPens, regardless of how many thousands of dollars you have to pay for them, that they're simply not making them. Our drug shortage problem is still very real. I send through to Chief Guadagno regularly the drug shortage reports from across the country. That's my national responsibility, is to keep track of the drug short problem, and to work with Chief Ludwig and the other people on our responses to that. There is some light at the end of the tunnel, and that is the hospitals have gotten tired of this and are producing they have funded their own company to make our basic medicines. And one of my jobs nationally is to make sure that they're going to make the medicines that we use and that the hospitals share them with the EMS world. Epi, sugar, salt water, bicarb, atropine, all the basic medicines we need that are very cheap, that the drug companies can't make enough billions of dollars now to make for us. And so the hospitals are creating their own company, and that is our long-term solution to our drug shortage. That's still probably 6 to 12 months away, just so you know. And in the meantime, there's still drug boxes that don't have stuff, or it's packaged different, or we don't have D10, we don't have D50, we have D10, etc. So everybody knows that's a problem. And the EpiPens now are not available. They're particularly not available in the pediatric size. And we get calls for panicked people because their kid got stung or ate some peanuts. And don't be saying that the parents aren't doing their job. Typically it's that they've tried and they can't find them, or it's $700 or $800 after insurance to try to buy those. It's a pity, and we can't do anything about it right now. All right. Pink puffers. These are COPD patients who have lost their ability to open their chest, typically big barrel chested, and they've lost their ability to expand their lungs, and so they can't get air in. Our job is to help them get air in. People with what we call blue bloaters, people who've destroyed enough of their lung tissue that they don't get CO2 out and can't get O2 in, then typically we get a call because their O2 levels are low. They may have their own oxygen device, and our job is to supplement oxygen, and oftentimes these people need a treatment and some Solumedrol, one of the steroids. Okay. Pneumonia. What is pneumonia? Infection, and it fills the lungs with fluid. CPAP usually work for pneumonia patients. It can work, but just so you know, a little different set of fluids in there. It's pus, and so those people, if they're short of breath, some of our stuff doesn't work. I showed Chief Guadagno a new device. I'm sorry for you guys on the computer, but we have a new generation of thermometer devices coming out that are simpler to use than our probe devices here. And we have these available. I assume you're going to talk about them later.
Yeah.
But anyway, the new generation of devices is infrared, and they work. And probably the way you will be using them is you will take the device, and I opened my mouth, and I got a reading. I'm at 99 degrees. This is probably the way we will be taking temperatures in the field in the future. This will be chained to something so that it doesn't walk away at the house, or everybody thinking that these are fun things to use. This is the next generation of tick devices. And this, for the EMS people, can also detect ambient temperatures. If you think it's cold inside, want to be able to tell the emergency department, it's 82 degrees in the apartment in the middle of the winter. It could tell the how much liquid is in a cup, etc. So a tick device for EMS, and is much cleaner than our other probe devices. So pneumonia is a bad disease. It's typically seasonal. Those people can get in big trouble. They're tripoding the same way, but they're typically febrile and are talking about coughing a bunch of stuff up. And those people typically don't respond well to any of our treatments and need to go to the hospital for antibiotics, and typically they end up intubated, unfortunately. A special form of pneumonia. What do you do if the patient is coughing up blood? I'm coughing and I'm coughing up blood. Put a mask on who? On the patient. Is that a good idea? Excellent idea. But they can't breathe.
Turn the oxygen on.
Turn the oxygen on underneath their mask. Still works fine. Coughing up blood, what am I worried about? What are you worried about? TB. You traveled recently? Yeah, I was doing mission work 3 weeks ago in a third world country. Okay, coughing up blood is two things, lung cancer or tuberculosis. And the form of tuberculosis that's active and contagious. And so a very good thing is a mask on the patient to begin with, and then the next mask goes on you. All right. Anybody want to review lung sounds? You okay with these? Thank you. So our protocol for respiratory distress. Position of comfort is always number one. If the patient's found a way to breathe, don't mess it up. So if they're tripoding, leave them in a tripod. If they're up over the top of the car, leave them up over the top of the car. They say I can only sit on a stretcher if I leave my legs dangling. Their legs are dangling. So these respiratory patients can need that kind of support, and for you not to mess it up for them by forcing them to lay down. Always good to begin with oxygen and some moisture. Oftentimes that moisture is albuterol.